are modifiable factors by the patients. Next slide. So the WHO established way back in 2013, a set of 9 voluntary global NCD targets for the year 2025, aiming at 25% reduction in the risk of premature deaths from NCDs. 2025 is just around the corner, but this slide gives you a good summary of the essential areas of intervention for the prevention of NCDs through the control of its common risk factors. So we are focusing here on premature mortality from NCDs, which is like 25% reduction in it. Next one, please. In line with FIP's mission to advance and to support the global health by advancing the pharmacy practice, science, and education, FIP launched 21 FIP development goals last year, that is in September 2020. One of the development goals, that is DG15, that is people-centered care, focuses totally on NCDs. So non-communicable diseases or NCDs are indeed a top priority for FIP, and this is reflected in the FIP development goal 15, focusing on people-centered care, which is entirely devoted to the important group of conditions. Can we go to the next slide? Yeah. So this slide summarizes the pharmacist role in NCDs. Pharmacists can play a variety of role in NCDs, that is targeting different population groups. So suppose if there are healthy people, pharmacists can guide them with healthy people. They can help them to continue to stay healthy through health promotion activities and education and disease prevention support. Those patients, those people with medium or high risk, who can be called as medium or high risk individuals, pharmacists can play a role in disease screening to identify those patients that need follow-up care and treatment and refer them to the appropriate healthcare professionals. With people with a diagnosed NCD, pharmacists can play a role in monitoring the evolution of the disease through disease state management programs and to optimize and help in optimizing the treatment outcomes and adherence. So pharmacists have a role in all types of patients, and they have a major scope, challenges as well as opportunities when it comes to diabetes. Next slide, please. So discussing specifically about the prevention role, what role pharmacists can play in diabetes prevention, which we are going to discuss today. Pharmacists can make patients aware of the potential of preventing type 2 diabetes from developing, that could be primary prevention, as well as the steps that can be taken to prevent its progression to avoid any complications, that is secondary prevention. Pharmacists can help in they can do the motivational counseling for the patients who wish to make and sustain these lifestyle changes, healthy diets, physical activity, maintaining a healthy body weight. All of us and all of you will agree that lifestyle modifications has been one of the most underutilized health aspect, and pharmacists can motivate their patients to adopt the lifestyle changes. Pharmacists can also develop educational materials, or they can take it from different organizations such as pamphlets, flyers, fact cards, banners, and they can use it through the pharmacy. Pharmacists can provide general education to the patients regarding healthy lifestyles via posters, lectures, social media campaigns, or informal conversations during counseling sessions. And pharmacists can provide comprehensive and long-term counseling on lifestyle changes. Next one. So the role of pharmacists, why it is so important in screening and referral. In low-income countries, 67% of the patients, that is almost 2/3 of the patients, are estimated to be undiagnosed with diabetes. Even though it is so easy to diagnose this disease, 67% of the patients are not aware or remain undiagnosed with diabetes, compared to approximately 38% of the patients in high-income countries and nearly 53% patients in middle-income countries. So people don't know their numbers. I mean, they never go for the medical checkup, and they are not aware that they have this condition. So undiagnosed type 2 diabetes can be especially dangerous, as it can lead to several micro and macrovascular complications like heart attack, stroke, kidney failure, blindness, and so on. It is imperative to identify individuals with diabetes who have not been previously diagnosed and refer them to the appropriate care. So pharmacists can play a big role in this area and can try to find out the patients with diabetes, and they can refer them to the appropriate healthcare professionals. So that's why pharmacists must be aware of who is at risk of potentially developing diabetes. So they should be able to identify the people with risk, who should be screened, how to conduct point of care screenings, and what to do if a test indicates a patient may have diabetes. So this is what, next slide, please. So these are the learnings which we will have from this digital event. And I'm most pleased to welcome our panelists for today and to discuss about the lifestyle changes, lifestyle modifications. We have a speaker here from Nigeria. Welcome, Margaret Wona. She is the founder and pharmacist, the Diabetes Care Network from Nigeria. She is a pharmacist and a public health enthusiast and a diabetes care advocate. Her passion for public health is public health literacy, especially as it concerns diabetes, led her into publishing her first book titled 7 Hacks in the Management of Type 2 Diabetes. And that marked the 2020 World Diabetes Day. It was published on last year's World Diabetes Day. Congratulations, Margaret.
Thank you very much.
Margaret is the founder of the Diabetes Care Network. And this network is an initiative that leverages on technology and social media to equip people with type 2 diabetes, their caregivers, healthcare practitioners, and all lovers of knowledge with the right information and management techniques aimed at fostering health literacy in the community. Margaret is also the author of two books, Managing Type 2 Diabetes with Ease and Eat to Beat Diabetes. She advocates for the healthy diet, which goes a big way in prevention of diabetes. Through her counseling sessions, diabetic patients have been able to achieve consistent glycemic control. So great to have you. Thank you very much, Margaret, for accepting this invite. And I welcome you to the floor. It's all yours. Over to you.
My pleasure. Thank you very much, Manjiri. Okay. Hello, everyone. I'm Margaret Wona. I'm a pharmacist and I'm from Nigeria. So I'll be talking on providing diabetes awareness and health promotion by pharmacists in the community, case study from Nigeria. Next slide. Okay, so this is our outline. We'll be looking at the introduction, the pharmacist's unique advantage, roles of pharmacists in providing diabetes awareness and health promotion, challenges faced in carrying out this work, especially for us here in Nigeria, recommendations, conclusion, then you get the references. Thank you. Next slide, please. Okay, so the global prevalence of diabetes has quadrupled in the past 3 decades, and diabetes mellitus has been identified as the 9th major cause of death worldwide. Now, this stat is troubling because the reason why I started the Diabetes Care Network was when my mom was diagnosed as type 2 diabetic. So, and again, just under 500 million people worldwide, that's about 6.25% of the world's population are living with diabetes. And the number is projected to increase by 25% by the year 2030 and a whopping 51% by 2045. And if we want to see a downward trend in this projection, I believe we as pharmacists have a role in promoting health awareness, and because prevention is better than cure, because one in every 11 adults with diabetes mellitus, 90% have type 2 DM. So no doubt, type 2 diabetes is the most common form of diabetes. Next slide, please. Now, the World Health Organization reported that people living with diabetes globally increased from 108 million in 1980 to 422 million in 2014. The question is, what happened? I believe it's because we did not utilize the effect of promoting health awareness on healthy lifestyle, because as we can see, being overweight and obese were the major risk factors associated with coming down with type 2 diabetes. Now, it is also estimated that in 2019, 463 million adults aged between 20 to 79 years were living with diabetes mellitus. No doubt, DM is a growing epidemic with global proportions. Next slide, please. Now, the Nigerian story. My country has a very interesting story. Nigeria has the highest prevalence of diabetes mellitus in Sub-Saharan Africa, with a prevalence rate of 4.99%. The amazing thing is this was not the case 5 decades ago, because between 1960 to 2000, the rate was low. We recorded a prevalence rate of about 0.8 to 2.8%, with type 2 being the most common among patients. However, a study conducted by Davis et al. In 2017 showed that the prevalence rate of type 2 DM increased from 2% in 1990 to 5.7% in 2015, accounting for an increase from 874,000 cases to 4.7 million cases in 2015. So this stats is troubling. The number of people with diabetes in Nigeria and the world over is increasing at a geometric progression. Next slide, please. Also, a study conducted in 2018 showed that the South-South geopolitical zone recorded the highest proportion of DM. Now, this is not surprising because the South-South geopolitical zone has a higher standard of living there because it's the oil-rich region. And because of that, people no longer paid attention to their health and their lifestyle, because it was also observed that physical inactivity, unhealthy diets, and age were the most important risk factors for DM in Nigerians. Also, most Nigerians believe that diabetic foot ulcer, which we all know as a complication of DM, but some persons in Nigeria still believe that DMFU is as a result of them being caused or hexed. It is amazing to find out that in a study conducted, 70% of the population ascribed diabetes to poisoning. So how do we change the narrative? How do we get them to better manage diabetes if they don't believe that it's a normal disease but ascribe it to being poisoned? It is also interesting to note that 78% of study participants agreed to determining their glycemic control by either testing their urine or passing urine on the ground and observing for ants to infest it. So this goes to show that pharmacists need to step up their game in promoting facts around type 2 diabetes. Next slide, please. Now, the pharmacist's unique advantage. Pharmacists are the most trusted healthcare professionals. And in Nigeria, community pharmacists are the first point of contact most Nigerians make whenever they are ill or have any health challenge. This is because pharmacists have positioned themselves to be the most trusted healthcare professional in Nigeria. And therefore, we are strategically positioned to provide diabetes awareness and health promotion in our community. Now, the roles of pharmacists, or the things pharmacists can do in promoting health awareness in our community, include this point, but of course, they are not limited to just these 5 points. What happened?
We can hear you, Margaret. Go ahead. We can hear you well.
Oh, okay. Sorry for that.
Yeah. Continue. Yeah.
Okay. So pharmacists can provide comprehensive diabetes self-management education, independent direct patient care, targeted pharmacy-based services, drug stability and safety. Then can also establish smart goals for management with our patients. Next slide, please. Now, in providing comprehensive diabetes self-management education, we as pharmacists can explain the condition and treatment options available to our patients, because I've noticed that patients achieve better control, or we achieve better therapeutic outcomes when the patient is in line or they are fully aware of the disease condition, the risk, and the advantages of properly managing it. We can also have detailed counseling section with our patients on what lifestyle modifications entails, because there's lots of conflicting information as to what to eat and what not to eat, to the point that most patients with type 2 diabetes end up starving themselves because they are scared of eating foods rich in carbs. But if we as pharmacists can come up with the right information and explain the truth to our patients, we're going to see better outcome. They can also take it a step further by explaining the various glycemic indices of the foods we have locally and how they impact on our sugar control. Then we also need to study food-drug interactions, especially for the foods available locally in our various country of residence, okay? Because in my country, this popular vegetable interacts negatively with metformin. So when patients take the two together, they don't see results and it can be disheartening. The next slide, please. Okay, under targeted pharmacy-based services, pharmacists can teach their patients how to accurately use the glucometer, because it doesn't make sense for our patients to want to taste their urine in order to ascertain glycemic control. But if we can make the glucometer available and teach them how to use it, it's going to go a long way in getting better outcomes. Then we can also carry out routine patient food care in our premises. It's one thing to inform them to always check their foods, carry out food care at home to prevent DMFU. But if you can actually carry out this service in our various practice settings, especially those in the community, it will go a long way to practically teaching them how to go about it. Then regular blood pressure checks, and provision of a plasma glucose logbook. This is one initiative I was able to come up with, because if they have a logbook wherein they are able to record their fasting blood sugars as they check it, it's going to help them trace how well they are able to achieve glycemic control, then identify possibility for an acute or chronic complication, so we can know when to refer to the appropriate health professional. Next slide. Now, independent direct patient care. This works the most, because if you want to see results with your patients who are diabetic, it is very important that you set up accountability programs. Because if you want to go far, you can go alone. But if you want to see good results, it's best you hold your patients by the hand. If the patient is confident that you're always there for them, they'll be able to do the right thing and get good results. So when you set up accountability programs where you can have bi-weekly or monthly meetings, as the case may be, during those meetings, you can review the SMART goals you both established, you in conjunction with your patient. Then you seek out ways of addressing any adherence issues. I found out that when we have these weekly meetings with our patients, we tend to get better results over time. Next slide, please. Now, challenges, cultural beliefs. In Africa, especially in Nigeria, where most people feel that they are being chased or poisoned, we need to teach our client that these are myths, they are not facts. So although there's this barrier to cultural beliefs, we can still change the narrative. Then illiteracy, most patients do not know how to take their medications or how to check their sugar levels. But I believe that if we can talk to their relatives, their children, their caregivers, they'll be able to surmount this challenge. Then financial constraints. In my country, 99% of our people foot or pay their medication bills out of their pockets. So it can be a very big challenge in the management of type 2 of diabetes as a whole. Then lack of functional health insurance coverage and fake drugs. This is also a very big challenge for us. Next slide. Now, recommendations. To effectively promote diabetes awareness, pharmacists need to niche down. I realized that when I decided to focus on diabetes, I was able to give my best, my all to patients who are diabetic. So if you're able to specialize, I believe that we'll be able to better reach those people other than being everywhere at the same time. So I therefore recommend that we as pharmacists should take out our time to niche down. If we have more people talking about diabetes every now and then, what lifestyle modification entails, we will see that the awareness ratio will increase. Then traditional methods of educating our patients will no longer be enough. At least we learned this from the pandemic. During the lockdown, we could not meet our patients as we used to. So rather than sitting down in our various practice settings and waiting for our patients to come to us, we can take the message to them, to the community, by leveraging technology like social media. We can use social media to our advantage in spreading the news, the facts around diabetes. our patients are on social media, their children are there, their relatives are there, their caregivers are there. So if we can utilize that medium to spread the message, I'm sure it's going to go a long way. Then we can provide these educational materials in written, audio, video format in a form that is very simple and relatable. Then there's need for continuous pharmacy training on diabetes. Now, in conclusion, the global prevalence of diabetes is alarming. To effectively change this trend, pharmacists who are uniquely positioned in providing optimal care for patients with diabetes need to rise to the challenge of leveraging technology in promoting health education. These are the references, and thank you for your time.
Thank you so much, Margaret. That was very, very interesting and informative presentation. And the facts that you highlighted from Nigeria, I mean, the lack of health literacy or literacy is known to everyone, but the beliefs that the population carries, the myths or the misconceptions that they have. So I can see you have a lot of challenges, but also the strategies. Yes, the strategies or different programs which you discussed are very interesting, and I'm sure that will go a long way. So I agree with all your recommendations, and all the best to you to bring out the transformation in the pharmacy practice and the diabetes landscape. So thank you again for enlightening us. And we move on. Yes, we move on. I'll come back to you with questions towards the end of the webinar. So we move on now to the next interesting presentation. And we have a speaker from Portugal, Paula Texaria. She is Scientific Information Manager at Center for Medicines Information and Health Interventions in the Portuguese National Association of Pharmacies, ANF, since January 2015. And she has got specialization with immunization and diabetes are her main areas of expertise. She got her degree in pharmacy in 1999 from the Faculty of Pharmacy, University of Lisbon. And she's got 16 years of experience in community pharmacy and 3 years of experience in hospital pharmacy. Her passion is for public health interventions through the community pharmacies and providing the specialized inquiry services to the pharmacist from community, hospital, or other facilities. So welcome, Paula, and thank you very much for accepting this invitation. And floor, it's all over to you. Over to you, Paula. Welcome again.
I think I have.
Welcome, Paula. We can go to your presentation. Yes.
Can you see me?
Yes, we can see you, and we can see your presentation as well.
Okay. Thank you. Thank you, Manji. Thank you very much for the introduction. And it's a pleasure to be here today. And I would like to thank FIP for the invitation. Today, I will present a project on type 2 diabetes screening promoted by the Portuguese National Pharmacy Association, ANF, that took place between late June and September of 2019. The name of the screening was Diabetes, Descobrir para Prevenir. In Portuguese, of course, that means diabetes, find to prevent. Next slide, please. So, in Portugal, as in many other countries in the world, type 2 diabetes represents a major public health issue that assumes an unavoidable dimension and relevance, whether in terms of quality of life or health costs, that is emphasized by population aging and obesity epidemic. Next slide, please. As you can see, in Portugal, the prevalence of type 2 diabetes is very high. For the population between 20 and 79 years old, the prevalence is 13.6%. That means that over 1 million Portuguese people have diabetes, but only 7.7% is diagnosed. So we have almost 6% of the population between this target of ages that does not know they have diabetes. These data are from 2018, probably with almost certainly to the present day, this number is higher. Next slide, please. And when we look to the Portugal intermediate hyperglycemia prevalence in the same target of ages, we see that reaches 28% of the population. That is the same to say that 2.1 million people have intermediate hyperglycemia. Next slide, please. So, in conclusion, we can say that 41.6% of the Portuguese population between 20 and 79 years old has diabetes or intermediate hyperglycemia. That is close to 3.2 million people, which constitute a huge problem. We know that pharmacists are well positioned in the health team to take action on diabetes prevention and early detection, contributing to the reduction of diabetes complication. So, next slide, please. Knowing this, INF, the National Pharmacists Association, MEDIS, a Portuguese health insurance company, and GoFar, a joint venture between INF and the AGEAS Portugal group, who includes MEDIS, joined efforts to develop and implement a type 2 diabetes prevention and control solution for the population by combining their strengths. INF, with their pharmacies network and the knowledge from CEDIM, Center for Medicines Information and Health Interventions, and CEFAR, Center for Health Evaluation and Research, MEDIS, with their physicians and labs, and GoFar with their call center. As I already told, this was a type 2 diabetes screening. It was framed as a social responsibility in the population of the municipality of Gondomar, near Porto, in the north of Portugal. Next slide, please. So what was the patient journey in a macro way? In the pharmacy, we had identification of people at highest risk of type 2 diabetes through the application of the questionnaire Find the Risk, the Finnish Diabetes Risk Score, and the measurement of HbA1c. Our inclusion criteria were 45 years of age or older, not a diabetic nor taking diabetes medication, and if woman, not pregnant. Then the identified people were contacted by phone for scheduling a medical appointment. They went to the first medical appointment where protocoled lab tests were prescribed, later returned to the second medical appointment with the results for eventual diagnosis. Next slide, please. We had an IT support tool called Cifarma Clínico with a clinical pathway, a decision tree. The pharmacist started the Cifarma Clínico and collected the necessary information, verified if the person met the requirements, collected the necessary biometrics, applied the Find the Risk questionnaire, and if necessary, made the determination of HbA1c. The results were used in evaluation study. In the end, the pharmacy printed the summary of clinical information and handed it to the person. Next slide, please. There were promotion materials to the public, such as flyers and posters in the pharmacies, and we also had press releases, news in the local newspaper, and radio spots, and also material to pharmacy social networks. Next slide, please. So to participate, pharmacies needed to meet the adhesion criteria. They had to have INF IT tool, Cifarma, needed to provide general consumables to the HbA1c measurement, like lancet, gloves, cotton, and alcohol. The HbA1c analyzers and reagents were provided free of charge, and at least one pharmacist has to attend the training action. The pharmacies were paid 7.5 euros plus VAT for each Find the Risk questionnaire applied, and the same for each HbA1c measurement made. We had 29 associated pharmacies in this municipality, 22 were eligible, but only 14 accepted to participate in the screening. Next slide, please. The training action occurred at INF Porto with a duration of 4 hours. The program included a background about the impact of diabetes in Portugal and the risk factors, the pharmaceutical intervention and the patient journey, the study, the clinical pathway from Cifarma Clínico, practical training on HbA1c measurement, and key end-way. And we also provide an action plan, Cifarma Clínico procedures, intervention flowchart, and FAQ to help pharmacies. Next slide, please. In the beginning, I talk about the defined risk. So what is really the defined risk? Defined risk, the Finnish diabetes risk score, was developed in 2001 by the Finnish National Program for Diabetes. It's based on 8 questions about variables clearly related to the risk of developing diabetes, like age, body mass index, waist circumference, physical activity, eating habits, genetic risk factor, and blood pressure medication. It provides a measure of the probability of developing diabetes over the next 10 years. Next slide, please. So, the pharmacy intervention included, first, the identification of eligible people and invite them to participate in the screening program. If the person agreed to participate, the pharmacist need to collect informed consent and perform the defined risk questionnaire. If the risk was low, slight, or moderate, the pharmacy provided clinical information summary and promoted healthy lifestyles, which said in issued brochure made for general public that you can see on the left of the screen. If the risk was high or very high, the pharmacy also made the HbA1c measurement. If the result was below 5.7, the pharmacy provided a clinical information summary and promoted healthy lifestyles. If the result was above or equal to 5.7, the person was referred to a medical appointment, and pharmacy also provided clinical information summary and promoted healthy lifestyles. Next slide, please. The evaluation study carried out by CEPHAR was a multi-center and longitudinal study conducted in Gondomar pharmacies and in MEM office, the Physicians of Medis network. The key goals were estimated the prevalence of pre-diabetes and diabetes in the population who accepted to participate in the study, characterize socio-demographic and clinically the population involved in the study, assesses patient involvement in each phase of the program, and estimate the process indicators for those involved in the program, pharmacies and MEMS. Next slide, please. So in 17 weeks, the pharmacies applied 909 find risk questionnaires, performed 401 HbA1c measurements, made 94 referrals, and 35 participants got to the end of the journey and went to the second medical appointment. Next slide, please. Almost 17% were women and 30% were men, and the average age was 62. Next slide, please. By analysis defined risk, we can see that 73.8% were overweight or obese, 52.9% were physically active, 49.4% were taking medication for hypertension, 61.5% had high or very high waist circumference, 84.6% ate fruit and or vegetables daily, and 12.5% had history of hyperglycemia. And last, 56.8% had family history of diabetes. Next slide, please. So the results of find risk shown that in our study, we had 909 participants. We are facing 405 cases of participants at high or very high risk of developing diabetes in the next 10 years. So almost 45% of the participants. Next slide, please. Then the HbA1c results shown that 76.6% have HbA1c below 5.7. We made 401 measurements, so it means 307 cases. 20.7% had HbA1c between 5.7 and 6.4. It means 83 cases, and 2.7% have HbA1c above or equal to 6.5, so 11 cases. It means that 94 cases were referred to medical appointment. Next, please. So that 94 cases were contacted and only 56 scheduled the medical appointment for different reasons that you can see on the right side. Some were unreachable, others have already been followed by a daughter, and so on. Then 16 missed the first appointment. It means that only 40 went. Then 5 missed the second appointment, and only 35 got to the end. Next slide, please. From that 35 that got to the end of the journey and were diagnosed, we can see that 11 had already diabetes and 24 had a pre-diabetes situation, with estimated prevalence of 2.5 and 7.8 respectively. Next slide, please. In conclusion, we can say that 1 in 10 screened users needed a medical care. 4 in 10 screened users needed to adopt preventive lifestyle changes. And more important of all, 100% of screened users who finished the patient journey were effectively diagnosed. Next slide, please. So, as a conclusion, I would like to emphasize again the important role that pharmacists play in the prevention and management of diabetes. We should always keep in mind that diabetes is a silent disease, and its early detection is essential to prevent major complications. Work in a multidisciplinary team have a lot of benefits, especially for patients, basically giving them a much more effective support. In this particular project, pharmacists were able to identify patients with high risk of having diabetes and provided them an effective response in the health system that in this case meant a medical appointment. Next slide, please. Thank you for attending. I hope you enjoyed.
Indeed, Paula, we enjoyed your presentation, and it was a very, very interesting presentation because you gave us the facts and you gave us the results of your own screening campaign in Portugal. And the recommendations you have or the findings you have are very, very relevant. And you said it very well that diabetes is a silent disease. In fact, diabetes is a silent killer. And that's why pharmacists have enormous scope to help the community to find out and detect and screen the population and bring them on the treatment, and so that they don't go for the complications, they don't develop the complications. So thank you, Paula, and I'll come back to you
Thank you.
Yes, with questions later on. We have a lot of questions for you too. So we'll be back again. So right now we go to the next presentation, and we have a speaker, Dr. Mohammed Hassan Elnam, and he's the Assistant Professor of Clinical Pharmacy in Department of Pharmacy Practice, Faculty of Pharmacy, International Islamic University, Malaysia, that is Penang. Dr. Mohammed has graduated with a Bachelor of Pharmaceutical Sciences, and he obtained in 2006. Welcome, Mohammed. And then he obtained a postgraduate clinical pharmacy degree, PharmD, in year 2010. Both of these academic degrees were from the Alexandria University in Egypt. He also got a postgraduate certificate in clinical research from Harvard Medical School, USA in 2012. Then he has been certified as a pharmacotherapy specialist from the American Board of Pharmacy Specialists in 2014. He did his PhD in pharmacy practice from Malaysia in 2018. His research interests are mainly quality use of medicines, especially cardiovascular and diabetes pharmacotherapy, prescribing improvement, and pharmacist-led interventions, and pharmacy education, especially experiential learning. He has published several research articles, actually 45 full articles, and he has been reviewer in various peer-reviewed journals. So welcome, Dr. Mohammed, and we have an expert with us, and please go ahead and talk about your presentation. I'm sure it's going to be another interesting presentation. So look forward to it. Over to you, Dr. Mohammed.
Okay, thank you so much, Manji, for that kind introduction, and thank you for the FIP for inviting me for this very interesting event. Today, I will talk about how our pharmacists delivering diabetes preventive service in the COVID-19 era. The outlines, next slide, please. The outlines of my talk will be divided mainly between, I will link between diabetes and pandemic, some background information, and some link how the pandemic can affect diabetes care or diabetes prevention. Then the core of my talk will be focusing on pharmacist support in the pandemic era in terms of the rules that the pharmacist can do, the evidence, what patients prefer, and examples of successful model of care implemented during the pandemic. Next slide, please. So first of all, when we talk about diabetes and pandemic, it is good to highlight that diabetes itself is a primary risk factor for development of severe virus infection in general. Within the COVID-19 pandemic, we can see that patients are mostly will be developing hyperglycemia, especially the elderly one. And the risk of fatal outcomes with COVID is 50% higher in patients with diabetes compared to non-diabetic. And we can conclude maybe at last that diabetes is associated or linked to severity, increased severity and death in patients with COVID-19. So looking at all these adverse consequences, we can maybe better reflect back and think again, what if the patient is not undergoing all this? So the diabetes was prevented in this given case. Next slide, please. So when we talk about maybe diabetes prevention, we cannot overlook the American Association of Diabetes Educators revised model of care. And actually this may be quite interesting because they have listing 7 self-care behaviors that the individual at risk of diabetes or diabetic individual should adopt on regular basis. Very interesting, you can see maybe online, you can see the 7 self-care behaviors has different arrangement, but I believe this one is the correct one with the healthy coping as #1, as we can see in the figure on the right side. Healthy coping actually is the basis. Healthy coping means the patient have the support to develop and maintain positive attitudes toward the disease on the management on long-term basis. And this is actually very challenging. And when we are looking to the 7 self-care behaviors, we can think how the pandemic can affect all these behaviors. So initially, maybe the one involved will be directly affected by the pandemic, and this will transfer us to the next slide to see maybe the link, how diabetes prevention was affected by the pandemic. So first of all, when we talk in the self-care behaviors about the healthy coping as a basis for all others intervention to be done, because if the patient doesn't have the positive attitude toward the treatment, actually it is very hard to support or to engage him in healthy lifestyle changes that are done in daily basis. So first will be the psychological stress. Of course, all of us maybe were in this one when the pandemic come, a sort of uncertainty, a sort maybe of psychological stress coming from different resources. Of course, this affects healthy coping style of many individuals in the community. In the COVID-19 era, especially in the first year, all the problem or the focus and all the efforts, especially in healthcare organization, was focusing on treatment and the acute cases. What about the ICU? What about the ventilation, the complicated cases, all that stuff. So maintaining or thinking or structured prevention program at that time was not the top priority. Also, we can see the pandemic as a result of the lockdown or the movement restriction orders in general have affected how the diet and exercise habits of individuals can be maintained. And at last, the ability to have a regular follow-up visits also have been affected by the pandemic. So all these link directly to how the pandemic affects the diabetes prevention. So next slide. So now, what can the pharmacists contribute for diabetes prevention in the COVID pandemic? I think ensuring what the excellent presentation by the previous speakers, the pharmacist, of course, spread the diabetes awareness, provide support, and support is very important when we talk about revision. The American Association of Diabetes Educators have revised the terminology from diabetes self-management education to diabetes self-management education and support, in enlightening or highlighting the importance of support on long term for the patient to achieve or to be prevented from developing diabetes. Of course, promotion of health through the diet, the physical activity, the weight management, the smoking cessation, also very important. Provide point of care screening, detection, and referral services. And at last will be the credible public health information. This regarding the rules. So what about the evidence actually about how effective this rule will be? Can we go to the next slide, please? So the evidence, I think there's so many evidence in the literature, but here at the interest of time, I bring only 3. One from the perspective of the healthcare provider. This actually a national survey conducted in the US among the diabetes self-management training programs coordinator. And actually 1/3 of this program, the self-management, have a pharmacist as educator, diabetes educator, a well-trained pharmacist. And the coordinator of this program believe the pharmacist role is very beneficial for their patient. Also, in a comparative analysis in the US, when they compare the usual physician care compared to the pharmacist provided self-management education through meeting and telephone interviews, they found the pharmacist intervention was significantly has improved clinical outcome at 3 and 6 months basis. Also, in Malaysia, from the patient perspective, the patient still believe the community pharmacists have a wide potential role to do when it comes to diabetes awareness, management, education, and support. Next slide, please. So if you have the rule and the evidence, it is good all the time when we talk about support and patient engagement to think what patient prefer. So actually, this one of very interesting recent studies this a master thesis just published in conducted in University of Pittsburgh, USA. They were investigating what patients prefer when it comes to engagement in community pharmacy about the diabetes self-management education. So first of all, the initial engagement. The initial engagement, the interesting here that the patient feel comfortable face-to-face, email, phone, text, and phone call, relatively maybe all the means were relatively effective. But when it comes to communicating details about the program, the patient seems to be more comfortable to have something written, a brochure, flyer, a booklet, something like this. So this one of the important consideration when we think about starting or structuring diabetes education program. Next slide, please. Here, actually, one of the most interesting findings was when the patient were asked about their preference regarding the topic. What topic they prefer the pharmacist or community pharmacist to be engaged with them. And actually, from pharmacist perspective, I think all of us all the time thinking about the medication, the insulin injection, the monitoring, the side effect, and that stuff. And this, of course, very important. But from patient perspective, you can see here, among the highest topic will be the one related to the diabetes cooking classes, healthy eating, the diabetes friendly food, support on nutrition. So the health promotion and the contribution of the pharmacist in this domain is very valued and preferred even from the patient perspective. I believe there are so many activities to be done in this regard. Next slide, please. So now I will start to show some successful examples that conducted within the pandemic time. I will start by very good example conducted by pharmacy student during the epi rotation. They structured diabetes education webinar as a program to provide virtual diabetes education classes for their patients. The structure of the program was 4 weekly 30-minute class offered to patients even pre-DM or DM through Zoom. They cover maybe comprehensively the overview of diabetes, the diet, the exercises, and all the medication. The very important point, which is value most about this program, they also, in the program, they have referral services. They collaborate with the family medicine clinic in the university to refer patients at risk. And this is very important. And also they consider to give incentives for patients upon completion of the program, like maybe certificate or the pill box or something like this. Okay, and next slide, please. We have also one example from Saudi Arabia when they want to utilize the community pharmacist workforce to improve diabetes education in the community. And here, first of all, they provide diabetes education certification for a total of 25 pharmacists. They utilize them to provide 4 one-to-one counseling sessions. Every session will be about 20 minutes, will be scheduled over 2 to 4 month period. The content may be comparably like before, the medication, lab results, glucose monitoring, and that stuff. And the outcomes actually was very promising. They were able to improve the attitudes toward the diabetes, the overall diabetes awareness. And in some patients, some category of patients also, it has been associated with improved clinical outcomes. Next slide, please. We have also one more example about pharmacist-led diabetes class. And actually this may be a little bit different from before. Before we used to have maybe frequent session. Here, this will be designed on 1 monthly 90-minute educational class, including maybe around 66 patients. The content will be focusing on dietary exercise recommendation, the information about the disease, information about the medication. And actually, this one, in terms of outcome, have been associated with improved outcome in terms of weight. The patient weight decreased significantly, maybe 1.8. And also the hemoglobin A1C also was decreased in a significant pattern. Next slide, please. Coming here, during the pandemic, of course, we all hear about telepharmacy, telehealth, telemedicine all the time. So I will provide in this coming 2 slides some insights about the telepharmacy. One will be first, telepharmacy as defined by the ASH is the remote provision of pharmacy service by a qualified personnel. But actually, it is not something new. This model of care is well established more than 20 years. But what happened during the pandemic, that the uptake and implementation of this model of care have been increased in a significant way. You can imagine in this, some US healthcare organization, their telehealth and telepharmacy visits have been increasing from 100 visits in a month to 1,200 in a day. So this actually the main point during the pandemic. And also one good aspect about utilizing telepharmacy that you can customize, you can tailor the telepharmacy according to the patient needs. Whether this patient is pre-diabetic, so more stress on the healthy lifestyle and risk reducing intervention, or new patient, so injection or counseling or something like this, or later high-risk patient have immediate intervention to be done. Next, please. In a recent review that maybe summarizing all the telepharmacy maybe articles that have been published during the last few years, they found the most common platform or tool will be using the telephone, And this, we have 2 examples, one in Spain, using the telepharmaceutical care associated with free home delivery of medication. And the second come again from Saudi Arabia when they have multidisciplinary telemedicine led by pharmacists. And this actually have the name of virtual integrated care clinic. It's a very interesting model. And this was maybe in terms of impact, it decreased the physical consultation from 8 up to 2 visits in a 4 month. And also it reflects in the DM control and the medication adherence. But one good point we should consider when we think to adopt telepharmacy model in our practice, in terms of impact, the less significant impact or telepharmacy tend to be not that significant when the design of the intervention is less engaging for the patient, meaning maybe 5 minutes every 2 to 3 weeks. So actually this one was not enough to provide better engagement and the patient have something improved over time. So this one consideration. The second point, the least significant impact also is reported when telepharmacy compared to telehealth intervention by another healthcare provider. It was not actually significantly different. I think that's all the telepharmacy. Next slide, please. Here I will highlight maybe a little bit on the screening, detection, referral in terms of importance and consideration also. So during the pandemic, we can see on the table on the left side that according to the International Diabetes Federation, we can see that globally we have 230 million, around 230 million people undiagnosed diabetes. And you can see maybe the proportion undiagnosed is very high when it comes to Africa and Southeast Asia, followed by the Western Pacific. And of course, number 4 will be the MENA region. This actually a very maybe huge burden for undiagnosed diabetes. And of course, this one can relate directly how diabetes is increasing over years, because the undiagnosed diabetes problem is also is still relevant, and no major intervention have been curbed this one so far. On the right side, we can see link to various risk assessment tools. The tool provided by the Paula before, the Finnish diabetes risk score, the Diabetes Australia risk score, the Diabetes UK, diabetes from USA, and also we have one example from the International Diabetes Federation. The link are all here. I will provide one example in the next slide, please. This one from the International Diabetes Federation, the test to prevent. Very simple tool available in around maybe 11 different languages that can be easily adopted in practice to start engaging and starting discussion with patients who are at high risk or interested to be screened and to see what are the risks. Next slide, please. So when it comes to screening, of course, according to the WHO, we have to look for risk factors, which is well defined for diabetes. We have certain symptoms, we have certain signs, of course, and educating the patient about the common symptoms and when and how the screening, engaging with them, interpretation of the levels from normal to diabetes and in between the impaired levels is very important, and maybe a window for the pharmacist can contribute to the screening activity. Next slide, please. The last point regarding the screening will be, I will highlight some results from a meta-analysis, included all the work on screening in community pharmacy over around 60 years. They found pharmacies itself are very visible and effective sites to provide screening services. But the problem and the challenge all the time in the uptake of the referral. We can see from the previous case, not all the patients who have been identified at the beginning continue at the end. So uptake of the referral is always a challenge. The intervention, if we want to maximize the efficiency of such program, should be directed to increasing uptake of the follow-up testing. And coming again to the point of the support, the follow-up and the support. And a recent study, maybe just published this year, was interesting to highlight the factors that associated with the successful implementation of screening in community pharmacy. They found maybe how the engagement of the pharmacy staff, the pharmacy staffing, the operationalization and external engagement of the customers and doctors, and the link of the referral is very important determinant for the successful implementation such program. We can see on the right side, this one of the advertisement of one of the Australian pharmacists when they advertise for patients that the service are here, come, engage, and get your risk assessed. Next slide, please. Last but not least, in terms of the pharmacist role during the pandemic, will be the pharmacist as a credible centers for public health information. Actually, as maybe from academic point of view, we can see a huge scientific contribution, 100, even 1,000 every day of the paper conducted, posted, shared very rapidly. And we can see also some of them being retracted and proved to be dishonest study, and whatever the evidence they provided, they have to take back. So actually a pandemic with a paper-demic, like many information are there, with no control, and will be even more challenging to scrutinize, even by the healthcare professional. So what is the scenario for the patient? The patient actually, for them, is more and more challenging. So I believe a pharmacy, a community pharmacy, the most accessible healthcare provider, and maybe can play a role as a center for disseminating awareness, the credible public health information when it comes to, of course, the points we highlighted as a role of diabetes prevention contribution. Next slide, please. So in conclusion, I can say from this talk, I want just to provide this final message. Pharmacists can effectively contribute to the overall optimization of diabetes prevention using whatever the platform, even face-to-face with precaution, the telephone, telepharmacy, phone call, SMS, all this, or even virtual platform, Zoom, or any other examples, all are visible and all have been maybe mentioned in the literature to be effective tools for communication. But the most important, achieving the objective. When we talk spread that diabetes awareness, provide the support, promoting health, engaging more, and we can see from the patient preferences how they love the community pharmacists to engage more with them when it comes to healthy eating, the being active, the weight management, and that stuff. Also, we highlight about the point of care screening, detection, referral services that can be provided. And last but not least, provide credible public health information in the community. Next slide, please. And if you are interested to know more about maybe diabetes and COVID-19 pandemic from a pharmacist perspective, you may have a look on our article, maybe published earlier last year, focus or provide more details on consideration for pharmacists when they are dealing with diabetic patients during and post-pandemic era. Next slide, please. Thank you so much for the talk, and hope it will be helpful. Going back to Manjari, thank you so much.
Thank you so much, Mohammed. It was such an inspiring presentation, and you have given us a full overview of the great work done by the pharmacists during COVID-19 pandemic. Pharmacy profession has demonstrated its value ever than before during the COVID-19 pandemic, and some of the success stories, the evidence which you brought here is really very, very inspiring and encouraging for doing the further work. I also like the way you said that the pharmacists are the community health advocates and the trusted, the source of the trusted health information. Yes, so in the area of in the era of infodemic and the paperemic, as you said rightly, the pharmacists have a lot of responsibility to be the source of trusted health information. And that's why the World Pharmacist Day, which we just had the right team, pharmacy always trusted for your health. So from your studies and from your literature survey, we got the same finding. I also liked you gave us some references of the surveys. What do patients want? And you said about the nutrition and the cooking classes. So that gives us, a point to ponder that we should be including these type of topics in our pharmacy training programs henceforth. So thank you very much this was an excellent presentation. And here I want to thank all the panelists for your wonderful presentations. I can see a lot of appreciative messages in the chat. thank you all the attendees here who are appreciating the presentations and who have been very active. So that encourages us. Thank you so much. Here we are for the question and answer, and I request all the panelists, if you can come to the floor and start your videos, that would be very helpful to us. So thank you, Paula, thank you, Margaret, and thank you, Mohammed, again for your excellent presentations. And one question, there are many questions already answered by Margaret. Thank you, Margaret, for the same. One question, which I think answer is known to everyone, but then still there is a question, why do you see the diabetes increasing in such proportion? It is like an epidemic here. So why do you see diabetes is increasing in all parts of the world? So it is not just the developed countries, it is not just the LMIC, it is everywhere. So can you highlight, I mean, we know the lifestyle, the wrong diet, but what are the factors which you feel are most important contributing to this rise in diabetes proportion? Can I come to you, Paula? Can you hear me?
Yes. Can you hear me?
Yes, we can.
Yes. Like I said, we have effectively a lot of population that are aging, and we are facing the obesity epidemic. So a lot of factors contribute to this epidemic. Life changes, wrong food, and a lot of things that effectively contribute to this, and genetic factors also contribute. So we have our parents with diabetes, so it's the probability of we having with all of these things, I think we are facing effectively an epidemic, a very big epidemic that is going to bring us a lot of costs, a lot of problems, and the population is going to suffer with these factors.
True. Margaret, would you like to add anything? Your experiences in Nigeria, are people shifting and changing their lifestyle a lot? And is it contributing to the diabetes increase?
Yes, thank you very much. I believe lifestyle plays a major role in the increased rate we've noticed in diabetes, because here in my country, most people feel that eating fast food, eating junks is the new normal. Nobody wants to go back to eating fruits or eating vegetables or foods fresh from the farm. So I feel it's part of urbanization, and the fact that most people now prefer sedentary lifestyle to physical activity. So we have an increase in the amount of obese population. And there's this cultural belief that if you have a normal BMI, if you're on the small side, then you're not feeding fine. Such backward thinking has also contributed in the increased rates of people with diabetes, especially in my country. Because if you tell the patients to lose weight, they tell you that people are starting to mock them, that something, they ascribe it to being poor. So we have a lot of work to do in changing the mentality of our clients.
Yes, I understand. And I think bringing the behavior change is the biggest challenge that we have. And that's why the health communication has to be very effective. Mohammed, would you like to add anything here? Or shall I go to the next question? Please feel free.
Yes, I just will assure on the point of how effective the intervention done to maybe make this behavior intervention as a normal in the community. Actually, right now, we have a very well-known disease, a very well-known risk factors, but till the moment in the community, from even the healthcare provider perspective, the intervention was not that effective and sustainable. This is very important. When you talk about diabetes, sustainability of the effective intervention is a key. And I think this one is a challenge everywhere. To make a sustainable intervention over the time is very critical. Then the second point, of course, the undiagnosed patients come very late In some region, as I highlighted in my presentation, around 60% of the cases undiagnosed, coming very late and even coming with complication later. This make the problem of curbing the disease itself is very challenging as well. That's all from me.
Yes, I can't agree with you more. The sustainable interventions and finding out the people at an early state, diagnosing them and referring them to the healthcare professionals. So that's the situation we have seen in many parts of the country where we have more than 50% of the patients who remain undiagnosed, even though there are such simple steps to take for the diagnosis and everybody knows everything about it, but then the things don't go in positive direction. So here I just want to add one question. There was a question in the chat box. Do you feel that we should start screening or we should start checking the blood sugar levels at an early age? I mean, do you recommend checking the blood sugar levels or other diagnostic tools, use of diagnostic tools or some kind of surveys, even in undergraduate students? When would you like to start? What is your recommendation? When should we start, checking the people for their sugar? Mohammed?
I think that the screening in the first place is, I didn't find, according to my reading, I didn't find so much information about maybe getting cut-off limit at certain age to start. But most of the time, it does relate to the assessment of the risk factor in a given case. Of course, maybe later, 40 and above, of course, this may be increased risk for type 2DM, but younger age with having one of the established risk factors can also be considered for the screening. The screening should cover all the possible risk factor in a given case.
Right. So catching them young would be really beneficial so that we don't have the people with, increasing proportion of diabetic people after 1 or 2 decades. Definitely. Paula or Margaret, would you like to add anything?
No, I think maybe not so earlier, but for sure we must be alert to the risk factors. If we, in the pharmacy, if we saw a young boy or girl that shown the risk factors, I think we must alert the parents to go to the medical appointment to see, and maybe do the follow-up some in the future, but must be alert effectively to the risk factors that we can see in the pharmacy by just by looking. Sometimes we can alert the parents for the risk factors too, not only for them but for their children.
Yes. Thank you, Paula. So those with family history definitely they need screening at an early age. So there is one question: is the positive response to the community pharmacists because their services are free? Is there any reimbursement or charges or fees which are applicable in the community pharmacists for their services? So it could vary from country to country. And so Paula, could you tell me whether the community pharmacist gets any reimbursement, any fees for the work that pharmacist does for the community in the area of diabetes?
Our screening, the pharmacists were paid, but we had not the health system, the national health system, but a private. So the pharmacy were paid. Normally, in the other screenings, if you only have to measure the blood glycemia, it depends on the pharmacy. There are no value subscribed. The pharmacies they made the price they want. In this screening, no, it was a protocol screening project with a private entity. But normally the pharmacies are private and they practice the price they want.
Yes, thank you. There is one question. from Irina. I would appreciate if you could share information about countries where pharmacists work at diabetes clinics. Any answer, Mohammed? Dr. Mohammed, you would like to answer this?
Yes, I think I can share the experience here in Malaysia when we have maybe almost many of the public hospitals have medication therapy adherence clinic focus on diabetes. In this clinic, pharmacist is there, and the doctor or the physician will refer the patient for further support regarding many aspects of diabetes, maybe insulin, medication, monitoring, all these aspects. And this actually a private clinic in the hospital setting. It's very well established in Malaysia, I think maybe a few years back. So they are recognized and doing excellent work in this domain here in Malaysia.
Right, and there might be some more countries like UK, United States, where there are specialist clinics.
In my talk, I have maybe also mentioned about US.
Yes.
The National Diabetes Prevention Program have pharmacists as one of the main healthcare provider, and approximately maybe 1/3 of the program have a pharmacist as the educator, in this program as well.
Right. That is an interesting question where the pharmacist is saying that there are cultural and religious misbeliefs play vital role, as told by Margaret. She gave examples of the same. And many of the people are not adherent to the allopathic or the modern medicines, and they shift to the alternative medicines or traditional medicines on the way. So that affects their glycemic control, and then they get into some complications. So anybody has an experience of patients trying to opt also for the traditional medicines or alternative therapies, or and then getting into complications or any drug-drug interactions? Anyone has any experience in that area? No. Margaret, anything you want to add?
Yes, I do. I recently worked with a patient. He stopped taking his medication and decided to go herbal. So when they reached out to me, he was already having severe hyperglycemia. So we had to refer to the hospital, and we followed up. You don't just stop your medications because you want to adopt lifestyle modifications or use alternative therapy. You need a professional there in your team to teach you how to go about it. So yes, cultural beliefs is actually a very big challenge in managing diabetes, especially in Africa.
True. And we see the same in India, where people shift from one treatment line to the alternative medicines. And there is one more question. What do we do to stop self-medication in diabetes? Please, as witnessed in Nigeria today, what do we do to stop self-medication in diabetic patients? So again, the communication, the education of the patient, right? The pharmacist-led interventions would be very useful to keep track of patients and you know the best what works and what doesn't. Anything you would like to add? No. Okay. Yes. So thank you so much. I think this was very interesting webinar, and all the speakers have done excellent job. And we know diabetes is a big problem. The proportion of diabetes is increasing world over in all parts of the world in epidemic proportion. And we know that everything is known to everyone, that diabetes is a silent killer. We know the risk factors very well. We know the treatment very well. There are diagnostic tools, and there are many other ways to find out the diabetic patients at a much early stage, so that we prevent them from getting into the complications and premature deaths. We can prevent that. And pharmacists are doing wonderful work in this area. But as everybody said, that we need to have sustainable interventions, and we cannot just run the projects, but it should become a part of regular practice everywhere in the world. And the pharmacist, I always believe that the community pharmacies are part of solution to every public health problem. And diabetes is, of course, one of them, or in general, the NCDs. People walk in our pharmacies with a lot of trust, and we can guide them, we can influence their behavior. We are in a strategic position, as said by, rightly said by Margaret. And diabetes is a big challenge, but a big opportunity for the pharmacies world over. And the FIP has its ambitious program, as I said, one FIP, practice transformation. And we will be launching the publication, which I believe on 12th of November, the last digital event in this series. And I'm sure everybody would appreciate it and would use it and implement the services in their pharmacies. That will definitely be a ready reckoner and a support and a guiding tool for the pharmacists world over. So thank you again to all the panelists, and thank you very much to all the attendees whose enthusiasm and whose remarks and comments really encouraged us throughout the webinar. And thanks for attention. And then I will invite you and I'll remind you that the next webinar, the next digital event in this diabetes series is on the 22nd October. And please join us then. Thank you very much for attention. And again, see you in the next digital event. Thank you, everyone.